Welcome to the MediByte channel. I'm your host, and as a healthcare professional here at MediByte, today we're diving into a topic that is so incredibly important, yet, it's often totally misunderstood. We're going to be talking about female sexual dysfunction, specifically focusing on sexual interest/arousal disorder and orgasmic disorder. Now, I know this is a deeply personal and sensitive subject for a lot of people, but we are going to break it down completely, accurately, and in a really easy-to-understand way.
Now, I want you to think about this for a second. Temporary changes in sexual desire, they are incredibly common. It's only considered a disorder if it actually distresses the woman. That's the key right there. Fluctuations in desire are perfectly normal. Life, stress, natural biological phases, they happen to literally everyone. It only becomes a clinical concern when these changes cause you significant personal distress. Simply put, if you aren't bothered by it, it isn't a disorder. So here's our roadmap for this explainer. We'll be defining arousal disorder, looking at the 3 classifications, uncovering some root causes, understanding orgasmic disorder, going over diagnosis, and finally looking at multidisciplinary treatment options.
All right, let's jump right into Section 1, defining arousal disorder.
So, what exactly is sexual interest or arousal disorder? Well, it's basically a lack of or a significant decrease in sexual interest, sexual thoughts, or a lack of response to sexual stimulation. And we're not just talking about simply not being in the mood one night after a long day at work. For it to be this disorder, that lack of interest has to be persistent and present throughout the entire sexual experience.
Normally, when you feel mentally and emotionally excited, your body just kind of follows suit, right? Blood flow increases to the genitals, the clitoris, and labia swell, and natural lubrication happens. But with a disordered arousal response, those physical changes are either significantly diminished or they just aren't happening at all. It's like the body just isn't getting the memo from the brain, or sometimes those mental cues just aren't even there to begin with.
Moving right along to Section 2, the 3 classifications.
Now, this isn't a one-size-fits-all thing. It actually breaks down into 3 distinct classifications. First up is subjective. This is where mental and emotional arousal are totally absent, but get this, the physical responses, like swelling and secretions, are actually present. Then we have genital. This is kind of the opposite. The mind is aroused, maybe by an erotic story or video, but the physical body is uncooperative and sensitivity is reduced. And finally, there's the combined classification, where both the mental arousal and the physical responses are just minimal or completely absent. It really goes to show how complex the mind-body connection can be,
Okay, Section 3, uncovering root causes.
So why does this happen? Well, the root cause is usually this huge, intertwined mix of factors. Psychologically, we're looking at things like relationship struggles or just poor communication between partners. Mental health is a massive piece of the puzzle, too. Depression, anxiety, daily stress, or past trauma can absolutely shut arousal down. On the physical side, things like menopause and genitourinary syndrome of menopause can actually thin vaginal tissues, which makes intercourse painful and naturally decreases desire. And medically, chronic conditions like diabetes or multiple sclerosis can literally cause nerve damage, which blocks that vital blood flow and sensation. It's a lot to unpack, for sure.
And listen, we need to bust a really common myth right here. Young, perfectly healthy women are just as likely to experience sexual interest or arousal disorder as older women. Yep, you heard that right. It is not just an age-related issue. While older women might be dealing with natural estrogen drops, young women can experience massive hormonal shifts, like say during those first few weeks postpartum, that can dramatically, even if temporarily, derail their interest in sex.
Oh, and sometimes, the culprit is literally sitting right in your medicine cabinet. Certain medications are just notorious for tanking libido. Antidepressants, specifically SSRIs, are a huge one. But we also see this with opioids, anti-seizure meds, beta blockers for high blood pressure, and even excessive alcohol consumption. It is absolutely crucial to be aware of how the things we put into our bodies affect our sexual health.
All right, let's pivot a bit to Section 4, understanding orgasmic disorder. 1 in 10. Think about that for a second. 1 in 10 women never reach orgasm. I want to emphasize this heavily because honestly, if you've struggled with this, you are so incredibly far from being alone. It's a hugely widespread experience, and getting rid of the shame and normalizing this statistic is the very first step toward addressing it. Female orgasmic disorder is defined as a lack of, a delay in, or just really infrequent and less intense climaxes. But here is the absolute key part of that definition. despite sufficient sexual stimulation and mental arousal. This makes it totally different from the arousal disorder we were just talking about. In this case, the woman is mentally aroused, she's interested, but she simply cannot reach that climax. And that can stem from anything from consistently not having enough foreplay, to performance anxiety, to that physical nerve damage we touched on earlier.
Next up, Section 5, Diagnosis and Evaluation.
Now, you don't just walk into a doctor's office and get a clinical diagnosis because you've had a stressful month and aren't in the mood. According to the DSM-5 criteria, these symptoms, whether it's decreased interest or absent orgasms, have to persist for a minimum of 6 whole months. And going back to what we established at the very beginning of this explainer, it actually has to cause you significant personal distress before it warrants a medical evaluation.
When you do get evaluated, it all starts with your patient history. A good doctor is going to sit down and really listen to your own description of the problem. Because, hey, you know your body better than anyone else. They'll evaluate things against specific DSM-5 criteria, looking for at least 3 distinct symptoms to be present. They'll assess your level of personal distress. And finally, if you are reporting pain during penetration, they'll usually do a pelvic exam just to rule out other physical causes like an infection or endometriosis.
Which brings us to our final and most optimistic part, Section 6, Multidisciplinary Treatment Options. The best news here is that healing from sexual dysfunction shouldn't and doesn't have to fall squarely on your shoulders alone. This is really best managed by a collaborative, multidisciplinary team. You might start off with your primary care doctor or your gynecologist, sure, but your team could easily grow to include a specialized sex counselor, a psychotherapist, or even a pelvic floor physical therapist and pain specialist, depending on what your unique root causes are.
There are so many highly effective behavioral and psychological interventions out there. Often, it starts with something as simple as communicating to your partner what stimuli actually work for you and eliminating bedroom distractions, like kicking the TV out of the room to create a real sense of privacy and security. But I also really want to highlight a couple of specific tools. Mindfulness-based cognitive therapy is fantastic for helping you stay present in the moment without judging your own body. There are also sensate focus exercises, which is basically partners taking turns touching for pleasure without the pressure of having to have intercourse or reach climax. And frankly, incorporating tools like clitoral stimulation or vibrators can be a real game changer, especially if there is any nerve damage or reduced sensitivity. On the medical side of things, treatment usually starts with resolving any underlying pelvic pain. If that SSRI antidepressant we mentioned is the main culprit, your doctor might actually add a medication like bupropion to help offset those specific sexual side effects. And for postmenopausal women, there are some short-term experimental testosterone therapies out there. Though, a quick caveat, those require very close monitoring by a specialist due to potential side effects like liver issues or changes in cholesterol. But the main takeaway is that there are numerous, valid clinical avenues for you to explore.
So the big question is, are you ready to start the conversation with your partner and your doctor today? If you take absolutely nothing else away from this explainer, please remember this: you are not alone. Fluctuations happen to literally everyone, but your distress is valid and, more importantly, it is highly treatable. Thank you so much for joining me today. If you found this breakdown helpful, please do me a favor and like, share, and subscribe to the MediByte channel for more accessible, expert-driven health content. Until next time, stay curious, stay focused, and stay healthy.